Hello and welcome to CDC's Public Health Grand Rounds. Thanks for joining us. As you know, we have transitioned from live in-person sessions to virtual ones. To minimize any technical issues, we have recorded our speakers in advance, but they are all here with us today and will be participating in our question and answer session at the end of the presentations. Be sure to email your questions to grandrounds@cdc.gov. Dr. John Iskander is our host for today's session. Dr. Iskander?
Welcome to our August 2020 Public Health Grand Rounds on polysubstance use in pregnancy. I'm Dr. John Iskander with CDC's Office of Science. Thank you for joining us for our all-virtual session. Public Health Grand Rounds has free continuing education credits available for physicians, nurses, pharmacists, veterinarians, health educators, and others. The course code is PHGR10. That's Papa, Hotel, Golf, Romeo, followed by 10. Please see our website or the CDC Continuing Education website for more details. And here is our continuing education disclosure statement for this session. Grand Rounds is available on the web and all your favorite social media sites. Please send questions to grandrounds@cdc.gov, and we'll try to include your question during our Q&A portion of today's session. Want to know more? We have a featured podcast on our website called Beyond the Data, which is posted after the session. This month, I'm speaking with Dr. Suzanne Gilboa from CDC. We've also partnered with the CDC Public Health Library to feature scientific articles about this session. The full listing is available at cdc.gov/scienceclips. We thank our speakers and all of those acknowledged here for their work on this important session. Here's a preview of upcoming Grand Rounds topics. Please join us on the web at your convenience. And it's now my pleasure to introduce the Director of CDC's Office of Science, Dr. Becky Bunnell.
Hello, I'm Dr. Rebecca Bunnell, the Director of CDC's Office of Science, and I want to wish you a warm welcome to CDC's virtual Public Health Grand Rounds. Today, we will be discussing the co-use of substances, or polysubstance use, in pregnancy. To date, there's been considerable research on the effects and risks of single substance exposures in pregnancy. We know that use of substances, including alcohol, tobacco, and opioids, can lead to outcomes such as fetal alcohol spectrum disorder, neonatal abstinence syndrome, birth defects, and more. However, less is known about the impacts of multiple substances on pregnant people and their infants. This is a cause of public health concern, as recent research suggests that polysubstance use during pregnancy is common. For example, the National Survey on Drug Use and Health showed that among pregnant women, 40% of those who used alcohol also used other substances. Recent evidence has also shown that polysubstance use is highest during early pregnancy, a critical period of fetal development. There are several challenges to our understanding of polysubstance use. Stigma toward pregnant people who use substances can be a barrier to reporting, and there's a lack of standardized data around this issue. However, CDC and our partners are committed to overcoming these challenges to improve our understanding of polysubstance use during pregnancy and impacts on infant outcomes. Today, you will hear from speakers from CDC, the National Organization on Fetal Alcohol Syndrome, the University of Utah, and Michigan State University. The presenters will share the latest evidence on what is being done to improve our surveillance and prevention strategies for reducing polysubstance use in pregnancy. Thank you again for joining this CDC Grand Rounds presentation, as understanding polysubstance use in pregnancy is a critical step for prevention and promotion of healthy pregnancies and infants.
Our first speaker is Dr. Suzanne Gilboa.
Good afternoon. We are pleased to be able to share with you the current state of our knowledge around polysubstance use, or the use of multiple substances during pregnancy. By multiple substances, we mean use during the same time frame of, for example, alcohol and tobacco, or alcohol and opioids, or other combinations of two or more substances. Substance use in pregnancy can have negative effects on the pregnant woman and developing baby. Alcohol use during pregnancy can cause miscarriage, stillbirth, and a range of lifelong birth defects and developmental disabilities. These disabilities are known as fetal alcohol spectrum disorders. Smoking during pregnancy increases the risk of preterm birth, low birth weight, and oral facial clefts. Smoking during and after pregnancy also increases the risk of sudden infant death syndrome. In addition, e-cigarettes and other tobacco products containing nicotine are not safe to use during pregnancy. Opioid use during pregnancy has been linked to poor fetal growth, preterm birth, stillbirth, selected birth defects, and neonatal abstinence syndrome. Polysubstance use in pregnancy is critically important to address for at least three key reasons. 1, it is common. 2, it is preventable. And 3, the impacts of polysubstance use on infants are not well understood, and it is difficult to disentangle the potential effects of polysubstance use compared to the effects of use of a single substance. Polysubstance use during pregnancy is common. We know this based on data from the National Survey of Drug Use and Health, a nationwide survey that provides information on tobacco, alcohol, drug use, mental health, and other health-related issues among U.S. civilian, non-institutionalized individuals aged 12 years and older. From 2005 to 2014, 2% of reproductive-aged women reported non-medical opioid use in the past 30 days. Non-medical use was defined as use of an opioid pain reliever that was not prescribed or that was used only for the experience or feeling it caused, or heroin use. Among women of reproductive age who reported non-medical opioid use, 7% also reported stimulant use, 22% also reported tranquilizer or sedative use, 32% also reported marijuana use, 50% also reported at least one episode of binge drinking, and 56% also reported cigarette use. In a separate study of a Medicaid cohort of over 112,000 pregnant women in Tennessee, almost 42% of women taking opioid pain medication used tobacco. By comparison, 26% of women who were not taking opioid medications used tobacco. We recently analyzed data from pregnant respondents to the National Survey of Drug Use and Health from 2015 to 2018. We looked at past 12-month drinking, past 30-day drinking, past 30-day binge drinking, which was defined as 4 or more drinks on at least one occasion, and co-use of other substances among respondents who drank alcohol. Overall, the use of other substances was common among pregnant women who reported alcohol use. About 40% reported current use of one or more other substances, most commonly tobacco and marijuana. This graph depicts past 12-month drinking, past 30-day drinking, and past 30-day binge drinking by trimester of pregnancy. Pregnant respondents in the first trimester reported higher past 30-day drinking and binge drinking than respondents in the second or third trimesters. 19.6% of respondents in the first trimester of pregnancy reported past 30-day drinking, and 10.5% reported past 30-day binge drinking. In contrast, 4.7% of respondents in the second or third trimester of pregnancy reported past 30-day drinking, and 1.4% reported past 30-day binge drinking. These findings suggest that respondents decreased their alcohol use once they knew they were pregnant. These pie graphs illustrate the distribution of past 12-month and past 30-day binge drinking, drinking alone and in combination with other substances in pregnant females. In the left side pie chart, nearly 65% of respondents reported past 12-month drinking. 38% reported drinking without using other substances, and 27% reported drinking and using one or more other substances. In the right-hand pie chart, nearly 10% reported past 30-day drinking. 6% reported drinking without using other substances, and nearly 4% reported drinking and using one or more other substances. For both past 12-month and past 30-day use, the substances most commonly used with alcohol were tobacco and marijuana. Our team is also working on a systematic review of the literature around polysubstance use in pregnancy. We are in the middle of our analyses, but a few key gaps in the literature have already emerged. First, the findings from specialized study populations with particular inclusion and exclusion criteria are often not generalizable, and the studies are often quite small. Second, while many studies looked at multiple substances, often they did not report on combined use, and methods to define substance use varied from study to study. Third, reported substance use is not always objectively validated, so reports are subject to inaccurate or biased recall. Studies that do combine self-report with biochemical validation have good sensitivity for capturing women who are exposed to substances, but it is not frequently done. And finally, accurate capture of timing of substance use is difficult. Sometimes the use includes use outside of pregnancy, especially if the study asks about use in the past 12 months, but does not also include gestational age at the time of the participant's response. The U.S. Preventive Services Task Force recommends screening for unhealthy alcohol use in primary care settings in adults 18 years or older, including pregnant women, and providing persons engaged in risky or hazardous drinking with brief behavioral counseling interventions to reduce unhealthy alcohol use. The task force recommends that clinicians ask all pregnant women about tobacco use, advise them to stop using tobacco, and provide behavioral intervention for cessation to pregnant women who use tobacco. And medication-assisted treatment to address opioid use disorder during pregnancy can lead to more favorable outcomes. Compared to what is known about the effects of use of a single substance during pregnancy on infants, relatively little is known about the effects of combined substances. We do know that the risk of adverse health outcomes is higher for newborns of mothers who use multiple substances than for newborns of mothers using a single substance. We also know from animal studies that prenatal marijuana exposure can exacerbate effects of prenatal alcohol exposure on offspring development. And finally, from a methodological perspective, it is very difficult to tease out effects of single substances from multiple substances if studies do not adequately account for the use of multiple substances. It may be that what we know about a single substance may actually be attributable to polysubstance use, but it's not recognized because the information on use of other substances was not captured at all or not captured completely. The work that you will hear about today from our other speakers focused on the importance of addressing and reducing stigma toward women who use substances during pregnancy, the capturing of robust and detailed surveillance data over the duration of pregnancy and into early childhood, and the conduct of substance use screening and intervention are all critical elements of how we, as a public health community, are coming together to address polysubstance use in pregnancy.
Good afternoon. I'm Kathleen Mitchell, the Vice President and spokesperson for the National Organization on Fetal Alcohol Syndrome, or NOFAS, and it is a great honor to be participating in this important public health grand round. I've been working to prevent substance-exposed pregnancies for over 3 decades, and although there are many challenges, it's incredibly rewarding when we are able to witness a mother get the support she needs for a healthy pregnancy. I believe that stigma, blame, and bias towards mothers who have used a substance during pregnancy has impeded progress in prevention efforts. One problem is the wording that has been used for decades that blames or finger points to a mother's behavior, an unintentional consequence of our public health messaging. It's shocking that over 47 years of very solid research on the dangers of alcohol use in pregnancy and fetal alcohol spectrum disorders, or FASD, we still have healthcare providers and educated women who do not buy into the no alcohol message. Yet, when a child is born with an FASD or other adverse health outcomes from prenatal alcohol exposure, The blame goes straight towards the mother. In some states, they will even prosecute her. So it's understandable that women are afraid to discuss their use honestly with their healthcare providers. For the past 4 years, I have been a member of a research team looking into stigma towards birth mothers. Our 2017 study showed that birth mothers of children with an FASD were stigmatized more than any other group. The general public reported that they viewed these women with a much greater disdain, being more different and more responsible for their behaviors than women with mental health illness, substance use disorders, or women who had been incarcerated. When we pause and consider how stigma is acted out, it should really shock us all. As a society, we view these women as being more different or really less than me. That translates to a need to control these women. How we control these different people is we create laws that jail them and remove their children from them. We don't screen them routinely or discuss their substance use with them. We don't provide or seek out adequate treatment or even basic support. In order to fully recover, women need safe housing, trauma-informed services, inpatient care for themselves and their children, job skills training, transportation, child care, and definitely long-term support. So who are these terrible women who would endanger their own pregnancies? Well, they're women that may not even know they are pregnant, women who have received mixed messages from their healthcare provider or the media, and oftentimes they are women suffering with an alcohol or substance use disorder, a very treatable disease. They are often unable to stop using substances on their own and may not be able to access appropriate treatment. In 2004, I founded a program known as the Circle of Hope to support women who had used substances during pregnancy. In 2012, we surveyed 92 of those women, and of those 92, all but 2 women reported polysubstance exposures. In 2020, due to the COVID-19 quarantine, I founded a 12-step program, Recovering Mothers Anonymous, or RMA. Again, the majority of our moms are polysubstance users. I am a woman with that lived experience now in long-term recovery. There are many hundreds of thousands of women with a story of addiction and recovery similar to mine, but we are missing far too many that could be helped. Alcoholism, or alcohol use disorders as we call it today, is a disease, and it runs in my family. My father, grandfather, several aunts and sisters have suffered, and many have died from alcohol addiction. As a child, we didn't understand what alcoholism was. We only knew that when my dad drank, he acted differently. And many times there were family fights, and we were often scared. We grew up in chaos, with unpredictability, and trauma. But it was well hidden. We lived in a nice house with a well-manicured lawn, attended parochial schools, and church on Sundays. My teen years were troubled, and I could not even manage to get through high school. I experienced the symptoms of alcoholism very young. I was preoccupied with using alcohol and other substances. I had a high tolerance. I experienced blackouts or periods of time that I could not remember, and I had the family history. By the time I was 23 years old, I had 3 children, was on welfare, and had a husband who had been in jail. Remarkably, not one healthcare worker ever asked me about my alcohol or substance use. And looking back now, it had to be very obvious. That teen marriage did not last, and as a single mom on welfare, I struggled and fell into the bottomless pit of self-pity. Pour me a drink. Predictably, my preoccupation had progressed to daily craving, dependency, and use despite consequences. I tried to stop, but I was never successful. I was powerless and could not control the use of my alcohol and other substances. My life was utterly unmanageable and unpredictable. In a desperation to stop, I sought out treatment. I was put on methadone maintenance and Valium prescribed for my depression. I continued to use alcohol and nicotine. The use of those legal substances was never even discussed. Those were really dark years. It was like I was living in a fog. I made really poor choices. I married a man that suffered with addiction, and we had 2 children together. Sadly, both of those children passed away, one at birth, and my daughter died at 3 months of age from sudden infant death syndrome. I believe that both of my children died because I never had the benefit of treatment. I later discovered that my older daughter, who had been misdiagnosed until she was 15 years of age, actually had fetal alcohol syndrome. It's an understatement to say that my addiction harmed my children. Ironically, all I ever wanted to be was a good mother. My untreated addiction robbed me of that simple joy. I did finally receive inpatient treatment and was introduced to 12-step recovery. I'm really grateful to say that I've been abstinent from alcohol and other substances for over 36 years. I'm healthy. I don't suffer with depression or other mental health disorders. I'm happily married, and together we have 5 grandchildren, and not one of those children was prenatally exposed to any substances. Recovery opened many doors for me. I obtained a master's degree and continue to use my voice to impact how we address women, pregnancy, and addiction. I've developed curricula, published papers, taught courses at medical schools, and have spoken all over the world. I served on the World Health Organization Committee to develop guidelines for substance-using pregnant women, and in 2019 presented to the WHO FASD, A Vision for the Future. I share those successes not to boast, but to remind us that women with these lived experiences are valuable to the solutions we seek. In closing, I'd like to ask you please to take the time to talk to women and screen them for alcohol and other substance use. I can't help but wonder, what if? Maybe if someone had talked to me and, had asked me the questions, my children would have survived. One thing is clear: stigma and blaming has not worked. I believe if we truly care for women who may be suffering with a substance use disorder and listen to them, we can reduce exposures during pregnancy, help them to find their way to appropriate support. I've provided 2 links, one to the Circle of Hope and to Recovering Mothers Anonymous. Please refer women to us. Supporting women saves lives, and I thank you so much for this opportunity.
Thank you for the opportunity to present at the CDC Public Health Grand Rounds on putting the link in MATLINK, linking clinical data and surveillance of substance use in pregnancy. I am Marcella Smith, Assistant Professor in Obstetrics and Gynecology, and I'm presenting with my colleague and co-principal investigator, Dr. Julie Shakib, Associate Professor in Pediatrics at the University of Utah. What is MATLINK? MATLINK is a surveillance system to monitor maternal, infant, and child health outcomes associated with the treatment of opioid use disorder during pregnancy. The goals of MATLINK are, number 1, to improve understanding of the range of maternal, infant, and child health outcomes associated with treatment for opioid use disorder during pregnancy. And number 2, to examine the possible effects of exposure to multiple substances and other risk factors on maternal, infant, and child outcomes. MATLINK creates a data platform from our 4 sites to develop and collect linked maternal, infant, and child data associated with the treatment of opioid use disorder. This can serve as a model for collecting data on other exposures during pregnancy and to inform clinical practices and clinical decision-making around treatment of opioid use disorder among pregnant women. The MATLINK clinical sites were chosen based on local opioid burden, geographical, racial, and ethnic, and socioeconomic diversity, as well as the ability to link maternal, infant, and child data. The sites represent 4 different models of addressing opioid use disorder treatment among pregnant and postpartum women and the care of their children. With respect to our local opioid burden, Utah has the third highest prescription death rate from opioids in the country. The overwhelming majority of individuals with opioid use disorder in Utah initiated with prescription opioids, and our heroin-associated deaths have tripled over the last decade. While the rates of deliveries nationwide complicated by opioid use disorder has quadrupled in the past 2 decades, in Utah, the rate has increased nearly tenfold. Among pregnant women with Medicaid, 42% of women received an opioid prescription in pregnancy compared to 20% nationwide. I also sit on the Utah Perinatal Mortality Review Committee, which works closely with the CDC. We have found that opioid-related deaths are now the most frequent cause of pregnancy-associated death, which is the death of a woman during pregnancy or 1 year postpartum. The majority of these deaths occur in the postpartum period. For MatLink, we will focus on mothers receiving care in the Substance Use and Pregnancy Recovery Addiction Dependence Clinic, also known as SUPRAD. It is the only multidisciplinary clinic for pregnant and postpartum women with substance use disorder in Utah. We provide integrated obstetric and substance use disorder treatment for up to 1 year postpartum. We serve as the local and regional referral center and have multiple local partners, including residential programs for mothers and their children, outpatient treatment programs, and peer recovery support specialists. And now I'll turn it over to Dr. Shakib.
The Babies at Risk Identify, Guide, Empower Bridge Clinic is a post-discharge pediatric transition clinic that provides expertise in the clinical management of neonatal abstinence syndrome. This transition clinic was developed to avoid lapses in care for infants with opioid exposure. The primary goal of the Bridge Clinic is to reduce the risk of readmission and other adverse outcomes due to psychosocial barriers by serving as a medical home for this vulnerable population. Given the robust clinical operations of the 4 MatLink sites, we are able to provide detailed information about maternal health outcomes, including pregnancy, postpartum, and delivery outcomes. With respect to infant and early childhood outcomes, we have access to neonatal abstinence syndrome treatment data, including the rooming in model of care, medication use, and rehospitalization data. Our electronic data warehouse, as well as the Utah Population Database, a unique database that integrates medical and demographic data across health systems in Utah, allow us to track infant and child outcomes and provide detailed behavioral and developmental outcomes. As mentioned, we have integrated systems of care for mothers and their children. Because the majority of mother-infant dyads stay in our health system, we are able to provide detailed information about specific maternal medications for opioid use disorder, including methadone, buprenorphine, combination buprenorphine, naloxone, and naltrexone throughout pregnancy and postpartum. We also capture information on postpartum pain management. Because our electronic medical record is linked with the Utah Department of Health, we have access to clinical information for maternal deaths in the postpartum period. We also collect maternal data on hepatitis C treatment, which occurs in the SUPRAD clinic in the postpartum period, as well as documentation of custody status and developmental screening and referral outcomes for children. The MatLink project has thus far mapped current and future site-specific processes for preparing and submitting mother-infant linked data. Our 4 sites are currently reviewing variable lists for maternal health history, the delivery birth hospitalization, and maternal postpartum and child follow-up. So far, we have generated baseline case lists of mother-infant dyads and are currently pilot testing abstraction tools and providing summary reports. Along with the Public Health Informatics Institute and the CDC, the 4 MatLink sites are also participating in acceptance testing of MatLink information systems. MatLink's strengths include the core infrastructure and clinical site expertise necessary to help answer and ask critical clinical questions related to maternal opioid use disorder and related child outcomes. Many clinically relevant variables are being collected at each site for both mothers and children, and there is a rigorous process for data validation and transfer. Another strength is that all 4 sites utilize the same electronic health system record. One limitation is that the data was not originally intended for research purposes. These are clinical data, and it is important for us to note that privacy and confidentiality rules are observed. Another limitation is that each site has 4 different models of care for maternal-infant dyads affected by opioid use disorder. This has posed some challenges in the length of follow-up data available and the ability to compare follow-up data across sites. Another limitation is that different models of care include different types of providers of obstetric and addiction care services. At some sites, it is the same provider team, and at other sites, a team of different providers collaborate. However, this diversity in care models reflects the different ways health systems have addressed care for this special population by utilizing local resources. In this way, our 4 sites have been able to combine our collective experience in maternal and pediatric care and informatics to put the link in MatLink.
Hello, I'm Dr. Steve Andersma from the Michigan State University of Obstetrics and Gynecology and the Division of Public Health. My research focuses on the use of technology within healthcare settings for delivery of universal screening and brief intervention for substance use, particularly during pregnancy. In considering how to address use of multiple substances during pregnancy, it's tempting to think first about promoting sustained and intensive interventions, perhaps with even added intensity or duration. But those kinds of approaches are reaching only a very small fraction of those in need. As you can see here, using the latest data from the National Survey on Drug Use and Health, 85% of persons in need of treatment for alcohol or drug use has neither received any specialty treatment in the past year nor wants it. So it's critical that we proactively identify those at risk rather than waiting for them to come to us, and that we offer them an intervention that is brief and palatable enough to be acceptable to most of that population. Screening and brief intervention, which I'll call SBI hereafter, is designed to do just this. SBI is an evidence-based practice with a grade of B for use with alcohol among adults, including pregnant women. Typically conducted in healthcare settings, SBI involves universal screening for health risks such as alcohol, with provision of a short motivational intervention for patients who screen positive. Although there are many brief intervention models, they all generally involve some combination of eliciting the patient's thoughts about the possibility of changing their use, feedback about the possible consequences of that use, some indication of how the patient's level of use compares to local or national norms, a discussion of possible ways to change, and referral for more intensive services where indicated. But how well does SBI work? The short story is that SBI does reduce alcohol and tobacco use, particularly when the brief intervention is longer than just a few minutes and or more than one session or when presented by a physician. We also know that patients only rarely feel offended or upset when their healthcare providers raise the topic of substance use. Unfortunately, and not for lack of trying, SBI has generally not shown an effect on drug use, treatment seeking, or the negative consequences of substance use, such as negative health outcomes. SBI has also proven difficult to implement. For example, among adults who reported being asked about their alcohol use at a checkup in the past 2 years and reported current binge drinking, 80%, or 4 of 5 persons, were not counseled to reduce their drinking. And only 10.6% of obstetricians report using an evidence-based alcohol use screener. The evidence from large-scale implementation studies in the US and elsewhere also suggests that sustainable SBI implementation is extremely difficult. One study, for example, suggested that doing all United States Preventive Services Task Force A and B recommendations would take the average primary care physician an additional 4.4 hours per working day. Overall, there's a tremendous need for rigorous research seeking creative ways to enhance SBI's efficacy. As but one example of this, the current literature offers little guidance regarding whether and how we can address multiple substances. For example, can we intervene on alcohol and tobacco use simultaneously with good results on each target? Or in doing so, will we dilute our impact such that we get no effect on either substance? Technology, or what I'll call electronic SBI or e-SBI, may be a fruitful path forward. It has many advantages in terms of reach and cost, It is capable of a wide range of sophisticated and interactive strategies with unlimited tailoring to each patient's characteristics, including language, and is uniquely amenable to large-scale trials seeking to enhance efficacy. Further, access to technology is broad and growing daily. Techniques for ensuring security and confidentiality of health information are well established, and importantly, technology can even allow patients to receive assistance anonymously, which can be a crucial advantage in seeking to address substance use. Finally, technology can leverage the only spot in healthcare where anyone has any time, the waiting area. I should also emphasize another key advantage of technology, that it can use even a very brief proactive healthcare encounter, such as in the waiting area, as the basis for extended contact long after that encounter is over. Subsequent text messages in particular are readily agreed to by patients. Once agreed to, don't require active intent to be received, can be tailored based on information gained during the initial encounter, and can include links allowing patients to readily access expanded content, such as videos, booster brief intervention sessions, links to local services, etc. Further, because of its low cost, e-SBI can also be repeated at subsequent healthcare encounters, which are especially likely during pregnancy. There's still a great deal of research to be done with regard to e-SBI, but the results thus far are promising. This summary is from specifically projects from our lab. Note that we've often demonstrated short-term doubling of abstinence among pregnant or postpartum women, and that e-SBI has compared well to person-delivered SBI. Notably, we're in the early stages of fully powered trial of an intervention for alcohol use in pregnancy using a factorial design to also evaluate the effects of adding text messaging and/or booster sessions to the single baseline e-SBI. We're also partway through a major effort to develop a powerful e-intervention authoring platform that will be free for research use. We've also had some encouraging early results from implementation studies. In an ongoing project supported by the Michigan Health Endowment Fund, we're testing rates of e-SBI implementation when clinic staff, usually receptionists, are responsible for giving patients an iPad at check-in rather than research assistants, and retrieving that iPad when the patient is done without additional staff or funding. Pre-COVID, we were achieving rates of 90% or better, which suggests that this approach may be more scalable than standard SBI models. In addition, in a CDC-funded project being led by my colleague, Dr. Amy Lurie, we are investigating e-SBI implementation for women throughout the Henry Ford Health System. Despite technology's advantages and the above-noted successes, however, the challenges are substantial. Although we can show clinic staff how to use e-SBI technology in a single meeting, we can't begin using it before clearing what is often a long and arduous approval process. Further, as simple as implementation is, we're learning that we must go well past easy and good for patients. We must also make the technology of immediate benefit to frontline clinicians as well as healthcare administration. For example, we need to take on the burden of administering and scoring measures and facilitate billing for screening. But succeeding at this requires interoperability with electronic health records, which remains a substantial challenge. In terms of next steps, then, I would make three primary points. First, I believe that technology should be the first consideration in seeking to expand SBI. Second, we should make e-SBI more than merely easy. It should be very attractive to frontline healthcare staff as well as administrators, such as by providing useful summary reports and facilitating billing. Finally, I believe that we should think big. There are, of course, some things that traditional SBI does that e-SBI can't do. But there are also many things that only e-SBI can do, and we should leverage that as we seek to expand the extent to which we can sustainably identify and assist non-treatment seeking persons. Thank you.
Hello, and we're now live. As you can see, our speakers are here with us today, and everyone is starting their videos again. and I'm going to let our audience know, our online audience from our web stream and also from Facebook Live. We take questions at grandrounds@cdc.gov. So please send your questions there. We'll get in as many as we can. We have had a few healthcare providers asking us, we would like to watch this, but we can't do it right now. So what can we do to see and get the full benefit of this session? And I want to let them know that this session, and in fact, every Grand Rounds session, is available on our website at cdc.gov/grand-rounds. So this one should be posted no later than Monday. And then and any of the sessions that you'd like to see. So please remember that and do send your questions. So let's start with one question from our from Samantha. She says, given the largely unknown impacts of polysubstance abuse indicated by speakers, the well-documented medical concerns of alcohol and cigarettes, the well-documented psychological value for infants remaining with the mother and having a consistent, stable diet, how do you respond to Child Protective Services intervention and criminal prosecution of women for substance abuse and pregnancy, including illicit substances such as prescription drugs, alcohol, cigarettes? What are you doing? Should providers increase medical and public health approaches and decrease criminal and Child Protective Service policing approaches to substance use and pregnancy? And I know that was a long question and a mouthful, but it's a lot that we really need to kind of talk about. So who would like to start with that one?
Hi, this is Susie. Oh, Kathy?
Unmute, Kathy.
Muted.
Kathy, you're muted.
Okay. Should I do that? Okay.
Yeah.
Kathy.
Just my thoughts. We don't, at NoFast, we don't support any law that would ever prosecute a woman for having a disease and not being able to control her alcohol or other substance use. I really believe if we had appropriate treatment centers and models available in all communities, and in most communities we do, there are opportunities for treatment that's what's going to solve the problem. If you look at women who have recovered, it's women who have had the opportunity for treatment and they're able to get their children back and be the mothers that they want to be. So this is not something we should be criminalizing. I'll see if other people have something to add.
Sure, I'd love to add. So I think one of the really important things, and I 100% echo what was just said, that this is a medical condition. So substance use disorders of all kinds are medical conditions, and there have been conceptualized both in pregnancy and I think disproportionately in pregnancy as a criminal issue as opposed to being a public health and a health issue. I think with the move has been really to push this more towards a medical condition and for really physicians to be treating it, midwives, PAs, the spectrum of providers. And I think we're seeing that in the educational opportunities from our med school down up to fellowships. And we now have addiction psychiatry and addiction medicine fellowships. I mean, I'm in, my clinic is running right now and I have a fellow with me right now. So we are certainly training people who also know those particularities around pregnant and postpartum women. The other thing that I would say is I appreciate that, you know, as we're part of the Matling study, that creating this body of evidence that continues to show that really this is a medical condition. Women do recover just like any other chronic medical condition. There is return to use, and that continued support and continued medical, behavioral, social support is really what the evidence-based treatment is, and not criminalization of a behavior that is treated very differently outside of pregnancy and with parenting individuals.
Absolutely. I'll throw in on that as well. I think the public health approach is greatly preferable for a number of reasons. One, the sorts of criminal and child protective services approaches are really predicated on an assumption of far more harm than is actually present with illicit substances. Those risks actually compare readily to those of a number of other sorts of prenatal risks that we don't attend to in that way remotely. The second reason I think it's of real concern is that it reduces access to care. People don't want to be truthful with their providers. They don't want to show up for care. And that's the absolute last thing we should be looking for with these families. And then finally, what we know from an awful lot of research is that there's absolutely no way for those sorts of approaches to be used equitably. In other words, folks who are women of color, women of lower SES, are absolutely more likely to be tested, to be screened, to be the subject of these sorts of approaches. And it just makes things worse all the way around. A public health approach allows us to take all of it in context, all of the substances, including cigarette use, which is equally a risk in terms of use prenatally, but doesn't get anything like this kind of attention. And I think if it did, it would change a lot of those approaches. So yeah, for me, those are three reasons why the public health approach is absolutely preferable and should be the way that we go with this.
Would anyone else like to comment on that question? I know there was a lot of, there were multiple questions in there. Anyone else have anything to bring to the group? Okay. One of our Facebook viewers commented that during pregnancy, emotional abuse is also an issue. Are you seeing some consistency or connectors between the emotional abuse and then the addictions? Is that something that you see fairly commonly?
Kathy, do you want to handle that one?
Sure. I put it this way: if someone is experiencing a substance use disorder, then emotional abuse kind of goes hand in hand often, unfortunately. So, it changes behaviors, it changes how people behave. And oftentimes it's not one person in the household, but there's several members in the household where behaviors are being changed, and there's emotional and verbal and sometimes physical or sexual abuse going on as well. So unfortunately, that certainly goes hand in hand where there's a lot of excess of alcohol or other substance use.
Yeah, I'll agree with Kathleen, and I'll just add that trauma generally is a risk. Substance use in pregnancy doesn't come out of a vacuum. It's often the result of a whole host of experiences, trauma being one of those. Untreated trauma is absolutely something that should be considered as a major risk factor, and you'll see an awful lot of it when you're looking at the particular population of women using substances in pregnancy.
I'll add here in Utah with our Utah Perinatal Mortality Review Committee, which is our committee that reviews maternal deaths, and in light of the CDC Hear Her campaign, we often say that we review these cases because we are trying to hear her, the women who died. And in Utah and increasingly across the country, we're seeing that really substance use and mental health are the leading causes of pregnancy-associated and pregnancy-related deaths. So this is everywhere. And one of the things that we saw in our review of moms that died was a very high rate of physical, sexual, and emotional trauma. And that was just mentioned in the chart. So I went through every single one of those charts, and it's usually written in a note. But what is not there is systematic screening and intervention. So to really echo kind of what the common themes here are, is that it is happening across the country to all sorts of different women. It needs to be something that's equitable, and it needs to be something that, especially if we're screening for trauma, that we know what to do with it. So having a trauma-informed response to it. So if we ask and then do nothing about it, we can actually be re-traumatizing women. So it's really a multi-pronged approach, but listening to women that have died, they are telling us that they went through a lot of emotional trauma.
We have a question from Steve in our Grand Rounds email box. It says, in discussing substance abuse in pregnancy, it would be helpful to discuss the predisposing factors and how these can be addressed. For example, higher rates of adverse childhood experiences have been shown to be linked to higher rates of substance use. Would you recommend a trauma-informed approach, which I think we just answered that one, but to substance use? Could you expand on that a little more? Or Sarah, maybe you can also talk a little more about the Hear Her campaign.
I don't know if anybody wants to address the trauma piece first. Hear Her is really focused on maternal urgent warning signs. So it is working to address maternal mortality and morbidity, but with a focus on the urgent maternal warning signs and really encouraging pregnant and postpartum women to reach out and talk to their providers when they have concerns, and encouraging support networks and providers to listen then when women do raise issues. So we're very excited to have launched that campaign recently. And the website is cdc.gov/hearher. And there's stories from women who have experienced pregnancy complications, and as number of resources for women and their support networks. Thanks.
I have another question here, again from the Grand Rounds box. When the e-SBI is used, it was mentioned that the results would be capable of being anonymous. How would providers be able to provide a person-to-person intervention? Would only some of the results remain anonymous, or would enough information be made available for providers to be able to have that conversation? Would an in-person conversation be as effective as anonymity and self-referral?
Yeah, this is a great question. Thank you. There are many different ways to arrange this, and I think the bottom line first is to think about e-SBI not as a replacement for traditional kinds of care or connections between the patient and their providers or a mental health provider. It's really a replacement for nothing, meaning the nothing that usually happens. The vast majority of folks don't end up getting identified or discussing their substance use with somebody, whether they're seeking care because they're afraid to do it or whether they're out in the community. So few ways that we've handled this. One, we've shown clearly that when we use that in the e-SBI, even if it's anonymous, to promote connections to others, for example, to suggest that they talk with their physician, we've doubled the rate at which they talk to their physicians about their substance use, the rate at which they bring it up. So that's one approach. Another approach we've used is to have two phases of the consent, one in which we say, look, your doctor has some questions for you, and we're going to share those with your doctor, and here they are. And then have a second section that says, okay, now we're going to ask you questions that can be only between you and this computer. If that's how you want it, we'll ask you later what you think. We go ahead and ask some of the really sensitive questions that might be more likely to be underreported.
Steve, you went.
Yeah, I know. I hit
okay.
my space bar while I was gesturing, and I muted myself. We say at the end, okay, would you like to share these responses with your care team, or would you like to not do so? And what we're finding is that at least 90% do choose to share those answers with their doctor. But I think the fact that we're giving them that choice and that option to have safety with that really stigmatizing information definitely helps. I think what we're getting is, rather than interrupting with the one-on-one conversation they might have with their physician, we're facilitating it. And on top of that, we're getting some access to those who otherwise would have not reported anything to anybody. So I think that's the real advantage there.
A question here from Katharina. Thank you for your Grand Rounds presentation on polysubstance use in pregnancy. I had a question about whether in your current studies and interventions, is there any consideration for screening for vaping substances, since this is also on the rise in our communities?
I'll take that quickly at the risk of talking too much. I think that's an advantage of technology, is that we can easily add new questions to the screener that get universally given to everybody as substance use evolves in the community. So different types of things pop up that can be easily added, whereas the sort of electronic health record-based protocols tend to be a little slower to evolve and respond.
And I'll just add that in our surveillance studies, we do capture tobacco use in all forms. Whatever is documented in the records, we would capture. So if it's vaping, nicotine use via vaping, or cigarettes, then it would be captured in MatLink, for example, or other surveillance systems.
We've had multiple comments, especially thanking Kathy for her sharing her personal story, and they are also sharing their stories of needing help and not having access to it. Marcus from Facebook also noted what a big problem it's been for him, saying he spent 20% of his income for the last 5 years due to this issue on his child. Can we speak to that kind of response as well, not just the treatment, but access to it and the costs involved?
If you're speaking about pediatric care, I think we know very little about prospective care for children and what it takes. So we're hopeful that through MatLink and other resources that look prospectively over time, we can get a better picture for what resources children need and how to best support them. That's the whole goal of collecting this data, is to actually drive good targeted public health interventions for both moms and children.
And I'll just add in, of course, my expertise is more in the world of fetal alcohol spectrum disorders, and we work with the American Academy of Pediatrics on this issue. But certainly there's such a vast spectrum of things, that in ways that fetus can be affected. And certainly in the case of alcohol, they are lifelong. And there's been some research studies looking into the cost of raising a child with an FASD, which can go into the millions of dollars. And that doesn't even begin to account for the special education and just the lack of support and the emotional toll on the parents that understand what the disorder is, but the disconnect with healthcare providers and educators and people that work in the mental health arena that just really are not well informed about it. So, and it's lifelong, and it gets really troublesome, certainly transitioning from adolescence into adulthood. So that's a huge topic. You can go to nofast.org to learn more.
I don't have the next question yet from our boxer from Facebook. So I'm hoping that one of you could share a little bit more about how we might be able to improve access. Access to care is a big topic that kept coming up. They're like, I don't have any money, I don't have any insurance. So I know you shared the links earlier to the NoFast site. But does anyone else have anything they can offer on that as a solution for that?
I'll just say that one silver lining of the pandemic has been the increase in use and access to telehealth, which I'm hoping will and expecting really will be sustained even after the pandemic has resolved, particularly for folks in rural areas who lack transportation. It can offer real advantages. It doesn't do everything. There are plenty of care modalities that we would want to be able to provide, but it's one piece that I think that can help and that I expect to be much more widely available moving forward.
One thing I can say out of Utah, again, the Perinatal Mortality Review Committee has, on the maternal side, certainly has recommended that pregnancy Medicaid be extended to at least a year postpartum, and that women don't need to go through that process where they lose their Medicaid. They may still be eligible, but there's a pile of paperwork that you are responsible for filling out, and then you lose. If you don't fill that out, then there's a gap in your care. We see that frequently happen. I mean, we like to say here, if you can make it out of the house with pants on at 6 to 8 weeks postpartum, you're a hero in our book, and that's not really the greatest time to be doing anything but focusing on yourself and your baby in the best of conditions. And then when someone is dealing with mental health issues or substance use issues or new mental health issues that may have come up in that immediate postpartum period, and getting to know their baby, that really is a huge barrier for care for all women, and particularly for those with substance use disorders. So extending that out really as long, we say 1 year postpartum, but I mean, continue on. It's not like it ends at 1 year. So really just expanding public policy to cover as many people as possible.
And we are right at our time to close. And first, it's been a pleasure to work with you, and it's just an amazing session. And thank you so much for sharing this valuable information. And I'd like to go to John now to close.
Thank you very much, Susan. Really just an outstanding session, a great example of a comprehensive public health approach, a coordinated maternal and child health approach. Really would like to thank and ask for a virtual ovation for all of our speakers and guests. As Susan said earlier, all of these materials, including the full session video, will be posted on our website within the next week. And please join us for future public health grand round sessions.
I should also note, when we go live on the web, we will also have the Beyond the Data podcast with John and Suzanne, and we're really excited about that as well. So thank you out there for tuning in again, and you can look for our next grand rounds. Will be next virtual grand rounds will be in November. In the interim, please go to our website again, cdc.gov/grand-rounds, and view any of the 110 or so sessions that we have there for you. Thanks again for joining us today.